we know about the gastric emptying time, that is around 4 hours. Okay. So, during that period there is the mixing of the food bolus with the secretions of the stomach. That means it has got the oxyntic cells or parietal cells, and also it has got zymogen cells or peptic cells, which gives rise to the secretion. One is the hydrochloric acid, oxyntic cells hydrochloric acid, and the next one, that is the peptic cell or zymogen cell, that is the pepsinogen, which is after activation it becomes the pepsin. Okay. So, during its journey, so what is the volume of the stomach? It is only 50 ml in case of a newborn child, and as we grow up, during pubertal period, the the volume becomes 1 liter, and in an adult it is 1.5 liters, and this is 1.5 liter sac nature has provided or God has created, for which the simple battle is going on in every field due to this presence of only 1.5 liter of sac. Now, you can see in what is the shape. In hyperesthetic person, it is cow horn in shape, and in aesthetic person it sags down. Okay. And what is the position? It is situated mainly in the epigastrium. We know there the abdomen is divided into different quadrants like epigastrium, right hypochondrium, left hypochondrium, umbilical region on the both sides, that is the right and left lumbar region, and in the lower abdomen, right iliac fossa, left iliac fossa, and hypogastrium. So, it occupies the epigastrium, right, mainly the right hypochondrium, and also a part in the left hypochondrium. I mean, if it sags down, so it may reach the umbilical region. Now, it obeys a rule of 2. That means it has got 2 ends. You can see one end is above, that is the cardiac end, and one end is below. Okay. So, that is pyloric end. Okay. It has got 2 borders, one on the right side, one on the left side. That means lesser curvature and the greater curvature. Okay. And again, the surface we are visualizing, that is the anterior, or when it actually the stomach becomes full, it becomes superior. So, that is antero-superior surface. Similarly, there is a posterior surface or posterior-inferior surface, which is not visible here. Okay. Now, there are 2 notches also in the here along the lesser curvature. You can see one dependent point, that is an angular notch, and at the cardiac end we can see another notch here, another notch, here and another notch is here. So that is called incisura. The first one is called incisura cardia and that is the incisura angularis or angular notch. So it obeys the law of two. Okay. Now it has got to the cardiac end and the pyloric end, or cardiac orifice and pyloric orifice. What is the situation of the cardiac orifice? It is situated near the fifth intercostal space. It can reach even. Okay. It can seventh. We know the seventh costal cartilage. Just behind the seventh costal cartilage, we can get. And how much away from the midline? It is 1 inch to the right of the midline. Similarly, then other end, that is the pyloric orifice, which is situated around the transpyloric plane. How we can draw a transpyloric plane? Just we can put one palm. Okay, and if we draw a line, okay, just below this is the gyphoid process. Just below the gyphoid process, one breadth of the palm of same person. Not like I cannot put my palm there, of same person. And if I draw one line, that is a transpyloric plane. That is called transpyloric plane. It is how much away from the midline? It is half inches to the right of the midline. And this cardiac end is more deeply situated than the pyloric end. Okay. And the cardiac, now about, you can see there are several parts. One is fundus, one is body, and one is pylorus. Now fundus, how you can draw the fundus? We know that notch is there, that is the cardiac notch, through which if we draw a horizontal line, then we can divide the stomach. The upper part is called the fundus. And what is the peculiarity of the fundus? Fundus contains the fundic gas. And in X-ray, we can discover the black shadow. That is the fundic gas shadows. And after a heavy meal, like if heavy lunch or dinner, there is accumulation of the gas. Okay, because aerophagia, during our eating process, we unknowingly we can engulf some air. So that air will settle at the fundus. Okay, and that area can reach up to the fifth intercostal space. And you know, in fifth intercostal space, 9 centimeter away from the midline, we will get the cardiac apex. So if there is an accumulation of that fundic gas shadow, that will just above the fundus, where we will get the diaphragm. Just above that, we will get the fibrous pericardium, and ultimately we will, above that we will get the heart, and there we will get the apex. So it will push the apex of the heart. Okay, so there will be palpitation. So after heavy meal, there will be a development of palpitation due to that fundic gas shadow may push that cardiac apex. Okay, so we can get the palpitation. So that is the fundus. Okay, so fundus. So if there is a peptic perforation, that gas can come out. If there is a peptic perforation means there is any perforation at any point of the in the mucosa, and throughout the mucosa and through, if there is a perforation, then what will happen? That gas shadow will settle just under the diaphragm. So that is another clinical sign, gas under the diaphragm, which is a radiological diagnosis of peptic perforation. Now about the body. What is the extent of the body? From the fundus and up to, we can find, if we draw a line from the angular notch and it will touch the greater curvature, and there is an opposed bulge. Okay, here we will get. Okay, so up to this point we can describe that part is the fundus. Now the next part is the from here up to this is the pylorus, and this pylorus is again divided into the proximal part, that is pyloric antrum, and the next part is pyloric canal. The pyloric antrum is again the extensive, that is 7.5 centimeters, and pyloric canal is only 2.5 centimeters, that means 1 inches. Okay, that means 3 inches and 1 inches. So, and here we can find in between there is another notch. Okay, that is sulcus intermedius. We can see there is another sulcus, that is sulcus intermedius, which divides the pyloric antrum and the pyloric canal. Now, if we see the if we see the interior of the so now the two orifice, two surface and everything. Okay, and now okay. Now here we can see another. I forgot to mention another thing, that is rule of 2. That means there is attachment of, you can see, peritoneal fold, one at the lesser curvature, one at the greater curvature. That is the lesser omentum, greater omentum. Okay, so lesser omentum, from the lesser omentum, the peritoneum fold will go up to the liver, and another part from the first part of the duodenum, it will go to the liver. Okay, so that lesser omentum again is divided into hepatogastric and hepatoduodenal parts. Similarly, another fold of peritoneum which is coming down, which from the greater curvature, that is the greater omentum. Actually, there are two folds of peritoneum like this. One is anterior fold and posterior fold. These two folds actually is continuous above as lesser omentum, then it covers the anterior and posterior surface, and it is continued as greater omentum. These two folds. Again, this two fold actually folds upon itself. So, two fold, if you fold two folds, if they get folded upon itself, so two fold will create four folds. So, ultimately the greater omentum has got 2 and 2, 4 folds. Okay, so there are 4 layers of peritoneum within the greater omentum, and you know greater omentum, everything little bit idea you have, it acts as an abdominal police. Now about the arterial supply, it also obeys a rule of 2 mainly, because along the lesser curvature there is one arterial necklace, and another arterial necklace is around the greater omentum. That the arterial necklace around the lesser omentum is from the right gastric artery and left gastric artery. And another arterial necklace from the right gastroepiploic artery and from the left right gastroepiploic and left gastroepiploic artery. So there is another arterial necklace around the greater omentum. So it obeys a rule of 2. Okay. Now, if we see the before that, we can see not only these 2 peritoneal folds, there are also other 2 peritoneal folds from the fundus to the diaphragm and from the fundus to the spleen. They are peritoneal folds. One fold goes towards the diaphragm and one fold of peritoneum also goes from the fundal area to the spleen. So that is from gastrophrenic and gastrosplenic ligament. Okay. So unless and until we cut these 2 ligaments, they are basically the peritoneal ligament. You can see one is the above, one is the gastrophrenic and another is gastrosplenic ligament. Okay. So the gastrosplenic ligament, we know this is the area through which the splenic artery, actually we can get the celiac axis, which gives rise to 3 branches. We know the celiac axis is present here. Okay. It gives 3 branches: left gastric, splenic and common hepatic. This splenic will go behind this stomach and it will reach through this gastrosplenic ligament, and ultimately it will reach, and that tortuous splenic artery will reach the spleen and it will divide into 4 to 5 segmental branches and it will enter into the spleen. And you know definitely about the histology of the spleen. There are white pulp, red pulp, hana. Okay, you know about. So that is the splenic artery. It goes. So now the anterior surface. Part of the anterior surface is directly coming in contact with the anterior abdominal wall. And there is a triangle. Triangle is created by the left costal margin, inferior border of the liver. Here we are getting the liver, left costal margin, inferior border of the liver, and there is a transverse colon, ascending colon, transverse colon, descending colon. We know that is the transverse colon. So ultimately we are getting a triangular area which is just in contact with the abdominal wall. So that is called gastric triangle. What is the importance of this gastric triangle? Suppose there is a development of carcinoma in the head of the pancreas, okay, or in the carcinoma in the body or the pyloric region. So ultimately that pylorus will get obstructed if there is a growth here, whether it is in the pancreas or any, or in the we are getting the cholangiocarcinoma. That means the carcinoma means cancer of the head of the pancreas, or in the gallbladder, or in the pyloric region, gastric carcinoma. So ultimately this outlet will get obstructed. or here it might be an obstruction. Suppose there is a esophageal carcinoma. Okay. So, suppose there is an esophageal carcinoma. The food bolus will not enter inside. So, here carcinoma is present, it can happen here in the esophageal end, it can happen in the pyloric region, it can happen within the body. Suppose there is a body region. So, if we can, suppose this area is free, and if this area is free, then we can introduce a tube. We can give an incision and we can insert a feeding gastric tube inside. So, we can make an alternate channel. Okay. So that is the importance of the gastric triangle. And another point is important, that is the trough space. When we are percussing, percussion means there are several processes. First, inspection of this area. Then we palpate that area. Then we do the percussion. So, why? When we are percussing over the lung, there is a tympanic, there is a particular resonating sound. Here is there, resonating sound. When percussing over the liver is a solid organ, we are getting a dull sound. When we are percussing over the stomach, we are getting a typical sound, that is called tympanic sound. Okay. And if there is enlargement of the liver or enlargement of the spleen, anything can happen. So, it can come and it can cover this area. So, here we will not get the tympanic sound, rather we will get a dull sound. So, trough space is bounded on the right, above and right by the lower border of the liver, above and the left by the lower border of the pleura. Okay. And on the left side, that is the spleen. So, below that area we get a tympanic sound, that space is called trough space. So, enlargement or any pathology in the liver, it can obscure that sound. If there is a pleural effusion, it can come down and it can obscure that area. Or if there is splenomegaly, it can come down, it can go towards this trough space and it will get obliterated. So, enlargement of liver, spleen, or there is a pleural effusion, that trough space will get obliterated and we will no more get the tympanic sound. Now, about so, if we go above the stomach, what we will get? Diaphragm. On the left side, we will get we will get the diaphragm, above the diaphragm, left lung, and on the right side you will get left lobe of the liver. Okay, so they are related. Now we are getting a complete picture of the anterior surface, but the posterior inferior surface is related to some structures. ছবিতে নেই না এটা, স্টমাক বেড। ওকে, আছে মোটামুটি আছে। Now we can see the outline of the stomach. Okay, stomach, suppose the stomach is removed and then we are getting different structures behind the stomach which forms a bed for the stomach, that is called stomach bed, especially in supine position, not in standing position. Okay, in supine position it forms a bed. So what are those structures we will get? We can remember it with a very funny mnemonics. Okay, there are several structures: diaphragm, kidney, pancreas, splenic artery, so and so, mesocolon, transverse mesocolon. Okay, then how we can, suprarenal gland, how we can remember? There is one mnemonic you can remember, that is Dr. Shotten Shen, S. Shen killed a patient cruelly and mercilessly. Doctor means diaphragm, left crus of the diaphragm. Shotten Shen, left suprarenal gland. Shen, that means splenic, tortuous splenic artery. Killed, kidney, anterior surface of the part of the anterior surface of the left kidney. Patient, pancreas, body of the pancreas. Okay, cruelly, left colic flexure, that is the transverse colon is going and creating a flexure. This is the transverse colon and it is creating a flexure going there and it comes down, so it forms a left colic flexure. Cruelly and mercilessly, mesocolon, transverse mesocolon. So these are the structures which are being formed by the stomach bed. So stomach bed sometimes appear as a short note in your MBA examination. Okay, clear? So you can see these are the structures. So পরেরটাই দেখাচ্ছিল, ওই দেখাচ্ছিল এটা এই। So these are the structures which forms the stomach bed. You can see the stomach bed. You can see the splenic artery. You can see the left crus of the diaphragm. You can see the pancreas. You can see the kidney. You can see the left suprarenal gland, mesocolon, left colic flexure. Right? You can see. So this is the stomach bed. Now about the arterial supply. এবার বলতে arterial supply বলতে আসছে। So you can see radiating arteries looks like a octopus. It looks like a octopus, no? There are 3 branches. That is the left gastric, left anastomosis by the left gastric and the right gastric. And this is the right gastric epiploic and left gastric epiploic, which is coming from the splenic artery. And also the branches are coming from the splenic artery, which is called posterior gastric artery. And from here, when it is from the splenic artery, when it is entering into the hilum of the spleen, it gives also some branches which are called the short gastric arteries. So left gastric artery, right gastric artery, right, left and right gastroepiploic artery, posterior gastric artery and short gastric arteries. So these are the arterial, and venous drainage corresponds with the arterial supply. Okay, so we know this right and left gastric vein drains directly into the portal vein. Okay, whereas we can see, and whereas the right gastroepiploic vein drains into the superior mesenteric vein and left gastroepiploic vein drains into the splenic vein. So superior mesenteric vein and splenic vein, here we are getting the pancreas. Okay, so behind the neck of the pancreas there is a formation of the portal vein, it goes up. So this is the venous drainage. Okay, now about the nerves, lymphatics, there are several group of lymph nodes. We can actually there are submucosal development of the within the mucosa. There are 4 layers in the within the stomach, that is the mucous membrane, submucous layer, mucous membrane, submucous layer, then we will get the muscle layer. There are 3 muscles. From outside inwards, they are longitudinal, then circular, and then we will get the oblique muscles. And most outside we will get the peritoneal layer, that is the serosal layer. So there are 4 layers. Now about the lymphatics, they develops from the submucosal area, submucosal plexus, mucosal plexus, submucosal plexus, and within the muscle myenteric plexus and subserosal plexus of there are lymphatic channels, and those lymphatic channels, they actually move around the arterial supply. We know left gastric artery, right gastric artery, splenic artery, around the splenic, around those arteries it will move, and ultimately they will drain from this area, from the left area. Okay, it will drain into the pancreatico-splenic nodes, group of lymph nodes, because here we are getting the behind the stomach bed, we are getting the pancreas ends, and here we are getting the spleen. So pancreas, within the hilum we are getting the pancreatico-splenic group of lymph nodes. From the right area we are getting several nodes. Here we are getting the liver, so these are the hepatic group of lymph nodes. Here we are getting the, this is the pylorus, below the pylorus we are getting the pyloric group of lymph nodes, and here we know right gastroepiploic and left gastroepiploic arteries are anastomosing. So here we are getting the gastroepiploic group of lymph nodes. So from here, this area it goes into the pancreatico-splenic group of lymph nodes, and which is been in between there is a relay center, that is the cardiac group of lymph nodes. From here cardiac, some goes to the cardiac group of lymph nodes, cardiac end to the pancreatic lymph nodes. From this area it will this is the, we know these are the area where we can call they are gastric group of lymph nodes, and ultimately they will enter into the celiac group of hepatic group of lymph nodes, and here we are getting the celiac trunk. So some nodes are there, so it will enter into the celiac group of lymph nodes. From here it will enter into the para-aortic group of lymph nodes, and ultimately there is a development of Cisterna we know, which goes where actually there is an opening of the diaphragm. Here there is a median arcuate ligament through which it passes, and there is development of thoracic duct. So from here, from this area, gastric group of lymph nodes, from there celiac group of lymph nodes, gastric group of lymph nodes, celiac group of lymph nodes, from this area, it will enter into the hepatic group of lymph nodes. Hepatic group of lymph nodes are present near the porta hepatis of the liver. In the liver, the lower surface or the visceral surface, there is an area which is called the porta hepatis. Port like, why? Through which the different structures enters into the liver. What is called port? All the materials are coming through the sheath and other things, they are coming and entering into the town. So that area is called port. So that is a porta hepatis. Around the porta hepatis, we are getting the hepatic group of lymph nodes. From here, celiac group of lymph nodes. From here, this area, we are getting drainage into the gastroepiploic group of lymph nodes, and from here it is entering into the pyloric group of lymph nodes, and ultimately hepatic, celiac, paraaortic, Cisterna thoracic duct, and ultimately thoracic duct will junction. Except the right part of the head and neck, right part of the thorax, right surface of the liver, right upper limb. That is by the right lymphatic duct of the body. Now about the musculature, I told you there are three muscles from outside inward, that is longitudinal muscle, one is circular muscle, and one is oblique muscle, which are oriented like this. Okay, around the fundus and the body, they are. So there you can see the interior of the stomach. Here we can see there are several folds which are called the gastric rings. Okay, and here this is the cut end of the stomach. So here we are getting the muscular layer, and the most inner layer is the oblique muscle, which moves like this. Actually, it is oriented like this from anterior surface to posterior surface. So, okay, they are oriented. Kirokom? From here, they are starting. The free ends are here. Okay, the oblique muscle, and it is covering, and it is ending posteriorly. So there are oblique muscles. So these oblique muscles has got anterior and posterior free ends. Okay, and these free ends, when it contracts, ultimately there is a development of a canal in front, that is called the gastric canal. That gastric canal is very important for what? Actually, the fluids, water, what we are drinking actually passes only through this. When we are drinking water or any fluid, it passes through the gastric canal. So any corrosive, it will go through the gastric canal. So near the lesser curvature. So lesser curvature is very much prone to development of ulcers, because there is a poor supply of blood. Okay, you will know. Next, there is a gastric canal. Okay, and if there is any corrosive material we are engulfing, like if we are alcoholic, that is again a corrosive. So that area can, or any spicy food can create ulceration at the lesser curvature. Next, nerve supply regarding again rule of 2. It obeys a rule of 2. It has got 2 nerves, 2 sets of nerves. That is sympathetic and parasympathetic. Okay. Sympathetic, what is the action of the sympathetic? Where they are given? This is parasympathetic, I will tell you. Sympathetic, they are coming from T6 to T9 segments of the spinal cord. And they are innervated towards the circular muscle. And pyloric, in the pyloric region, the circular muscles actually they are condensed to form a sphincter like area, that is pyloric sphincter, and this end is hard, and there is no anatomical sphincter in the cardiac end. So this area is soft, and this area we can identify with the bile stain, because we know the bile duct is opening in the second part. So there is a bile staining here. Okay. So and this area we are getting the pyloric sphincter. What is pyloric sphincter? It is a condensation of the mainly the circular muscles and deep layer of the longitudinal muscles. Okay, it forms a sphincter, and there is no connection between the circular muscles of the duodenum and the circular muscles of the stomach, because in between there is a septum, that is connective tissue septum. So carcinoma, cancer, it hardly goes to this side, because it cannot break the connective, it is hard to break the connective tissue septum, whereas the circular muscle of this area is continuous with the circular muscle of the esophagus. So the cancer of the stomach can go upwards towards the esophagus. Now I told you about the sympathetic nerves. Now sympathetic nerves coming from the T6 to T9 segment of the spinal cord. The lateral horn cells, we know the thoracic region, there are lateral horn cells. From there actually the sympathetics are coming, and it reaches the circular muscle and the pyloric sphincter, and it causes constriction of the pyloric sphincter. If there is constriction of the pyloric sphincter, it will delay the gastric emptying time. Okay, so there will be enough time of digestion. Sympathetic will cause, whereas sympathetic, parasympathetic, which are nothing but the anterior and the posterior vagal trunk. Parasympathetic is coming through the vagus nerve. 10th cranial nerve, actually it supplies the stomach. It supplies several organs: larynx, trachea, lungs, heart, cardiac plexus, pulmonary plexus, esophageal plexus, and ultimately anterior and posterior gastric nerve. Anterior gastric nerve, actually it is mainly by the contributed by the left vagus, and posterior gastric nerve is mainly contributed by the right vagus. Why? Stomach was like this. Okay, stomach was like this. During embryonic period, stomach was like this. Okay, in the sagittal plane, but due to its rotation, it moves to this area like this on the right side. Due to rotation of the liver, it rotates the liver, it rotates the stomach. Okay, so you can see this is the right vagus. Here we are getting the left vagus. So right becomes the posterior, and left becomes the anterior. So this vagal trunk, actually we can see they divide, and they looks like the legs of a crow. Legs of a crow. Right? These nerves are called the nerves of latter jet. Nerves of latter jet. So, what is the function of the vagus nerve? Vagus is secretomotor. It will create. It will supply the. There we are getting the cardiac glands, body glands, pyloric glands. So they supply the glands, cells, parietal cells, peptic cells, and there is secretomotor. That means secretion which is like a motor action. So there is a excess secretion. So gastric secretion will be increased and it will inhibit the pyloric sphincter. So it will reduce the gastric emptying time. Okay. So if there is excess stress, anxiety, it will pass through this vagus nerve, cranial nerve, and ultimately it will create excess secretion, and ultimately it will create the peptic ulceration, peptic perforation. So in that case we have to cut these nerves, which is called the vagotomy. Okay. So there are truncal vagotomy when the vagal trunk, selective vagotomy, highly selective vagotomy. That means only the branches only supplying the parietal cells which are been cut, because in truncal vagotomy this pyloric region will get affected. So it will not. So there will be dumping syndrome. You will know in physiology. Okay. So this is, and gastric emptying will be affected because it accelerates the gastric emptying. So if the nerve is cut, gastric emptying will be affected. Okay. Now about clinical anatomy. Already we have mentioned peptic perforation, okay, ulceration along the lesser curvature, okay, then vagotomy, okay, okay, it is done in case of peptic ulcer disease, okay, and these are vagotomy, truncal vagotomy, highly selective, so and so. Now about the most important part is how to hold it in anatomical position. How we can identify, this is cardiac end, this is pyloric end. You can see this end is very thick and this end is soft. Okay. So we will hold it in. So how we can identify the anterior and posterior? There is one bare area near the cardiac end, and on the posterior surface there is a bare area which is called the bare area of the stomach. There is bare area in the liver also. What is bare area? This stomach, you can see this is very much shiny because we are getting the peritoneum, but here we are not getting the peritoneum in the cardiac end on the posterior surface. Okay. So we will hold it like this. This is on the, and this end is pyloric end. It is in a superficial plane, and this is in the deeper plane. This one is 1 inch to the left of the midline, this is half inch to the left of the midline. This is the position of the anatomical position of the stomach. Okay. So this is lesser curvature, this is greater curvature. Okay. And this is the incisura angularis where we are getting a notch. This is lesser curvature. Lesser curvature is from the right end of the esophagus, it is continued up to the right end of the duodenum. From here, the greater curvature, it will go upwards and backwards, then it will go downwards, okay, and forwards and to the right, and it will reach on the left side of the duodenum, left border of the duodenum, okay, the first part of the duodenum. So this is anterior surface, this is posterior surface. এবার এসে ধরো দেখো, হোল্ড ইট নিজেরা, আমি তো হাতেই ধরলাম। আমাদের সময় গ্লাভস টাভস খুব একটা ছিল না, আমরা হাতেই ধরতাম।